Hi everyone, it's a pleasure to be here today. I'm Beth. I'm a research scientist at MIT in the Department of Biological Engineering in the Tall Research Group. The lab is led by Mickey Tall. In the lab, I lead research on the overlaps and comorbidities and shared pathophysiology across infection-associated chronic illnesses with a focus on long COVID, ME/CFS, and connective tissue disorders. I am particularly interested in the shared, less studied pathologies across illnesses that can significantly impact symptomatology and quality of life, such as hypermobility, environmental sensitivity, spinal conditions, and reproductive health conditions. I have nothing to disclose. So for the order of my talk today, I'm going to introduce this group of infection-associated chronic illnesses and discuss their overlaps, beginning with shared onset patterns, risk factors, and symptomatology. I'm going to focus on research on the prevalence of hypermobility and comorbidities and also touch on possible mechanisms. Then I'll be summarizing research literature and sharing some of my papers, as well as sharing for the first time preliminary research from our lab on these topics. I will be focusing on hypermobility and connective tissue disorders, but we'll also discuss other less studied shared pathologies across illnesses, including spinal disorders, environmental sensitivities, and reproductive health conditions. So I'm going to start by discussing long COVID and myalgic encephalomyelitis, or chronic fatigue syndrome, which I'll call ME/CFS, and then expand from there. So after about 6 months, about half of all long COVID patients meet diagnostic criteria for ME/CFS. The latest CDC Pulse survey results found that 5.3% of all US adults currently have long COVID. So this is a really significant number of people in the population. And these illnesses share many overlapping features and symptoms. So key shared symptoms include extreme fatigue, post-exertional malaise, which is an exacerbation of symptoms in cognitive or after cognitive or physical exertion, cognitive impairment or brain fog, orthostatic intolerance, and much, much more. They also share important pathologies, as you can see in Sarah and Chris's excellent figure, which include autonomic dysfunction, neuroinflammation, endothelial dysfunction, mitochondrial and bioenergetic dysfunction, and related metabolic dysfunction, immune dysfunctions, and more. Importantly, these are heterogeneous illnesses that impact many organ systems. That being said, these illnesses commonly overlap with a group of illnesses that share many similarities and have high rates of comorbidity. They include long COVID, ME/CFS, dysautonomia, chronic Lyme, HEDS, or hypermobile Ehlers-Danlos Syndrome / HSD, fibromyalgia, mast cell activation disorders, and really the list of comorbidities can even expand beyond this, but I'm going to focus on this group. It's common for more moderate and severe patients with infection-associated chronic illnesses to develop multiple conditions simultaneously with a complex picture and medical background. Unfortunately, historically, this often hasn't been well incorporated or captured sufficiently in research. Commonly, more severe patients and complex patients with these really highly understudied conditions tend to slip through the cracks of both research and medicine for a variety of reasons. I'm not going to go too much into that because that is a separate talk, but understanding why and how these conditions so frequently overlap, phenotypes across illnesses, shared mechanisms, common disease trajectories, and implications of these questions for study design, as well as clinical approaches to these illnesses and next steps for the field are a core focus of my research. So as I mentioned, I lead an area of research on this constellation of illnesses at MIT in the Tall Research Group, which is led by Mickey Tall. And illness clusters, as we know, are not unique to this group, but are commonly seen across diseases with shared pathophysiology. For example, patients with cardiometabolic diseases frequently have multimorbidity, including obesity, type 2 diabetes, hypertension, non-alcoholic fatty liver disease, and they have them simultaneously, which highlights shared etiology between these independent disease traits. Common pathologies across these illnesses include, but are not limited to, neurological conditions, including autonomic conditions, immune, neurocognitive, cardiovascular, mitochondrial, and metabolic dysfunctions, and more. So I've been working on a project looking at the history of the literature, documenting rates of comorbidities across these group of illnesses. And just for an example, I'm going to focus on ME/CFS here, but you could do this with any of these illnesses and go across. So within ME/CFS, in the literature, between 12 and 70% of patients may have POTS. That being said, in research, about 90% of adults with ME/CFS have reduced cerebral blood flow on a tilt. So one can have autonomic dysfunction and orthostatic tolerance and dysautonomia without necessarily the tachycardia response in POTS. So a meta-analysis revealed a 47% diagnostic overlap between ME/CFS and fibromyalgia. And with MCAS, there's a study of 160 ME/CFS patients that found that 7% may have MCAS, though there's a lot of complexity with testing for MCAS. With long COVID, as I mentioned, about half of long COVID patients may have ME/CFS. Another study found that a little less than a third of ME/CFS patients may have small fiber neuropathy. And as for HEDS and joint hypermobility, between 12 and 19% of ME/CFS patients may have HEDS, and between 50 and 81% of people with ME/CFS may have generalized joint hypermobility or joint hypermobility spectrum. So here's a list of some of their common overlapping symptoms. They include fatigue, cognitive dysfunction, chronic widespread pain, sleep issues, orthostatic symptoms, GI-related symptoms, hypersensitivities, including to new foods or environmental exposures, and symptom exacerbation around menses. In the interest of time, I am going to move on, but I think that hopefully you get the picture between me and the other speakers that there are many overlapping symptoms. And some things we are really interested in our lab is if there are subsets that share pathomechanisms leading to these shared pathologies. So next I want to discuss onset patterns and then risk factors before moving into the core of my talk, which is on hypermobility and connective tissue disorders across these illnesses, as well as other less studied pathologies. I also want to mention that all pathologies within these illnesses can be considered less studied because of the historic, lack of research and research funding compared to the patient population size and disease burden of these illnesses, but there are some topics that are especially understudied within our research. So among long COVID, chronic Lyme, ME/CFS, and POTS, the most common causes are infectious triggers, and many different types of infections can lead to these illnesses. So as I overview some details about onset patterns, one key research question we discuss in the lab is how can different types of triggers, including infections, environmental exposures, and injury, and often multiple successive triggers, lead to similarly presenting and overlapping illnesses, and how might onset patterns impact how we are thinking about treatment and recovery. It is also important to note that it's common for patients to report multiple triggers over time with gradual onset. So interestingly, there was a University of Colorado study in rats that demonstrated that SARS-CoV-2 protein activity may actually impact long-term vulnerability to other infections. And we already know that SARS-CoV-2 can reactivate latent viruses. So there's a lot of interesting research happening in that area right now. And if you think about it, the way we define these illnesses is really interesting. So according to the National Academies, long COVID is an infection-associated chronic illness that occurs following SARS-CoV-2 infection and is present for at least 3 months and affects one or more organ system. Lyme disease is caused by Borrelia burgdorferi, infection from a tick. Dysautonomia is autonomic dysfunction and has many different subsets and can be caused by multiple triggers, and then ME/CFS and fibromyalgia are a set of fairly similar overlapping symptoms that have really evolved in definition over time and can be triggered by many causes as well, largely associated with infection. And the road to developing these overlapping illnesses can sometimes be complex and winding. I hope that the complexity can be captured in research because there's likely a lot that we can learn from it as we try to better understand subsets across these illnesses. So viral reactivation and pathogen persistence is a really important area of research here. It's also important to note that infections can be non-symptomatic. So there may be patients who may not be able to identify all of their triggers. So among POTS patients, 20 to 50% report a viral infection as a trigger, though POTS patients can have acute or progressive onset. In a large study of POTS patients, 41% reported onset within 3 months of a precipitating trigger. Approximately up to 75% of people with ME/CFS report infectious triggers, though this number varies across studies. Viral triggers of ME/CFS include Epstein-Barr virus, human herpes viruses, Ebola, West Nile virus, Ross River virus, enteroviruses, and more. In a study of 231 college students with infectious mono, 10% developed ME/CFS 6 months after acute illness. And among a study of over 900 fibromyalgia patients, 5.6% could identify an infectious trigger. So infections are not just viral, clearly, but also bacterial. Chronic Lyme disease caused by Borrelia burgdorferi, with an estimated 10 to 15% of patients not returning to health, even after treatment with antibiotics. So something that's less known about is that patients also commonly report physical injury and other non-infectious triggers as preceding events prior to illness onset. This can include surgery, pregnancy, and childbirth, concussions, motor vehicle accidents, falls, etc. So in a study of 939 fibromyalgia patients, physical injury was actually the most commonly reported trigger. It was about 4 times more likely than infectious disease trigger. And just as a reminder that patients may not know all of their triggers, there are asymptomatic infections, and there are important limitations to these kinds of studies. In a study of 4,835 POTS patients, about 41% had infectious triggers and 31% had physical trauma triggers. Among ME/CFS patients, a minority also report accidents, surgery, pregnancy, etc. Environmental exposures are another commonly reported trigger of these illnesses, which I'll talk about in another slide. And that I hope that we can capture this kind of detail of multiple successive triggers across different subsets of patients, hopefully in our data as we continue to research these illnesses. So these illnesses all disproportionately impact female patients, and the sex differences in these illnesses are something we are really interested in studying in our lab. Akiko Iwasaki's lab at Yale found that low testosterone in women is a predictor for women developing long COVID. Also, a paper found that female long COVID patients have decreased neutralizing antibody titers, so it's possible that they may not be clearing infection as effectively. There are genetic and hereditary factors as well. Hereditary alpha tryptosemia is a genetic predisposition that increases one's chances of developing mast cell activation disorders, or MCAS. Genes have been identified for all subtypes of EDS except the most common form, hypermobile Ehlers-Danlos Syndrome. We'll talk a little bit more about that later. There are suspected possible genetic factors for ME/CFS, but more research is needed. In a survey study of 150 ME/CFS patients, 13% had at least one first-degree relative who also had ME/CFS. Severity of acute illness and multiple pre-existing conditions also increase likelihood for long COVID. A history of infectious illness is a risk factor for ME/CFS. Acute Lyme without antibiotics treatment obviously increases risk for developing chronic Lyme, and so forth. So now that I've talked a bit about this group and onset patterns and risk factors for them, and how frequently that they tend to co-occur, I'm going to discuss the prevalence of hypermobility and connective tissue damage and disorders across these illnesses. I'm working on research projects on this topic. There are significant rates of comorbidity between connective tissue disorders like HEDS and hypermobility spectrum disorders, HSD, and ME/CFS, POTS, and fibromyalgia. So this is not the first time that research has documented new onset musculoskeletal conditions and infection-associated chronic illness. So for example, musculoskeletal issues have been documented developing in children following rheumatic heart disease, and Lyme arthritis is well documented in chronic Lyme disease. So in ME/CFS, as I mentioned, 12 to 19% of ME/CFS patients may have HEDS, 50 to 81% of ME/CFS patients may be hypermobile. In POTS, in the literature, up to 31% of POTS patients may have HEDS, and then up to 90% of HEDS and EDS patients, respectively, may have POTS in a study of patients across EDS clinics. In fibromyalgia, a meta-study found that association prevalence, so how frequently they co-occur between HEDS/HSD and fibromyalgia, ranges from 68 to 90%, which is a lot. It's important to note that these rates of comorbidity are significantly higher than general population prevalence. So it's estimated that only 0.02 to 0.2% of the population may have EDS, and 3.4% may have symptomatic hypermobility, so joint hypermobility with widespread pain, which is of course significantly less than the prevalence within these illnesses. More research on connective tissue disorders in long COVID is needed, but around 23% of long COVID patients in a large EHR study fit within a phenotype characterized in part by having a higher prevalence of connective tissue disorders. COVID-19 is associated with a substantial risk for autoimmune and autoinflammatory connective tissue disorders in a large retrospective cohort study, and case studies document long COVID patients newly developing joint hypermobility post-COVID-19. Generalized joint hypermobility was found to be a risk factor for long COVID in a prospective observational study in the UK. Eccles et al. Found that hypermobility was also a predictor of fatigue in long COVID. I collaborated on a paper that was just recently published on the prevalence of comorbidities and hypermobility in long COVID with colleagues at the Mayo Clinic. The paper was led by my colleague and co-first author, Dr. Stephanie Grach, who is terrific and will be speaking here today at the conference. The study surveyed 247 people with long COVID at Mayo's long COVID clinic, as well as 40 controls, and it's a survey-based study. 27% of long COVID patients had generalized joint hypermobility, and this is compared to just 10% of controls. We also found that 58% of long COVID patients screened positive for ME/CFS compared to 0% of controls. And there were important sex differences here, with 53% of males with long COVID having ME/CFS, but 77% of female patients screening positive for ME/CFS. Orthostatic intolerance was also commonly found in long COVID and not in controls. In addition to demonstrating a prevalence for generalized joint hypermobility in our study, we also found that large subsets of long COVID patients in the clinic experienced new onset or worsening pain, neurological conditions, sleep issues, skin conditions, genitourinary conditions, allergies, and more. An interesting question that arises from this research is, could these new onset allergies in long COVID be indicative of mast cell activation syndrome? And one wonders if this could potentially increase risk for hypermobility, but obviously more research is needed to study these questions, and I'll address that thinking and those questions later in my talk. After looking at the literature on prevalence and comorbidity across these illnesses, some key questions emerge here, such as, are people with hypermobility at higher risk for these illnesses, as we've seen is the case with long COVID? Does hypermobility become more severe, more symptomatic after developing these illnesses? Do some people with these illnesses develop essentially an infection or inflammation related connective tissue disorder? This is something we are studying in our lab, both through mouse models and also through our clinical study, which I'll talk about in a bit. We hope in the future to be able to identify mechanisms of connective tissue breakdown in infection-associated chronic illnesses, and we're specifically interested in immune and inflammatory responses to infection and possibly the roles of persistent infection and mitochondrial and metabolic mechanisms, which I'll talk a little bit more about later. So speaking of our clinical study, I am honored to be able to share this preliminary data with you for the very first time. It's our first time ever sharing it publicly. So we in the TAL Research Group have designed and run a large and comprehensive clinical study at MIT on infection-associated chronic illnesses. Mickey Tall is the PI of the study, and it's a big collaborative project among many researchers, including myself. So we are conducting multiple different types of non-invasive neurological and neurocognitive testing, and we are also assessing for hypermobility and skin integrity. And we are collecting many different biological samples across multiple cohorts of infection-associated chronic illnesses. We hope this data will help us to identify biomarkers, therapeutic targets, and also better understand shared pathophysiology across illnesses. The study is ongoing and we are still bringing in participants, so this data is not reflective of our final data analysis. It's preliminary. But what we found is that among 23 people with long COVID, 17% had between 1 to 3 musculoskeletal conditions on the list to the left, which also includes HSD and joint hypermobility. And among 43 people with chronic Lyme, 26% had 1 to 3 musculoskeletal conditions, so multiple musculoskeletal conditions simultaneously. And this compares to just 7% of 29 controls who have 1 to 3 musculoskeletal conditions. So stay tuned for more data from our study. Speaking of cross-illness research, I think it will be increasingly important to study phenotypes across illnesses, given the substantial comorbidities and overlapping symptom presentations across them, and ask this question: is the presence of hypermobility a defining characteristic of a distinct phenotype shared across infection-associated chronic illnesses? So I'm going to briefly discuss 2 papers here. One is examining people who have ME/CFS with and without joint hypermobility and EAS. This is a survey-based study using a database maintained by SolveME, an ME/CFS organization. What they found was that in people with ME/CFS who had joint hypermobility compared to without, those who were hypermobile were more likely to be female, to have POTS, to have a higher number of autonomic, neurocognitive, headache, gut, and musculoskeletal symptoms, and importantly, they were more likely to experience more severe symptoms. So they were more likely to have worse health-related quality of life, especially related to physical functioning and pain. The second paper is a study that identified 3 phenotypes of people with HEDS based on comorbidities and symptoms. It was a survey-based study of 2,149 patients diagnosed with HEDS, and I want to especially highlight cluster 3 in the table on the slide, where 83% of HEDS patients in this cluster had gastrointestinal manifestation, 74% had dysautonomia, 46% had MCAS, 36% had ME/CFS, 36% also had craniocervical instability or atlantoaxial instability, so instability of the cranial junction, and 9% had tethered cord syndrome. So these are really substantial, and I think this kind of phenotyping research will be important to do across illnesses and for informing clinical approaches and clinical trial cohort construction and design in the future. And also, can we predict who will go on to develop this phenotype, and can we prevent it? I also suspect that more severe patients are more likely to be in this cluster, but more research is needed to characterize severe patients and also to better understand whether this is a phenotype that we see across illnesses. So that leads me to discuss spinal conditions and spinal disorders, often related to connective tissue disorders and may stem from ligament and tissue damage. A lot more research is needed on their roles within these illnesses and their prevalence, but these spinal conditions include upper cranial instability, such as craniocervical instability and atlantoaxial instability, as I just mentioned on the last slide, tethered cord syndrome, Chiari malformation, and cervical spinal stenosis, and more. So in terms of prevalence of these spinal conditions within infection-associated chronic illnesses, more research is needed, but I'm going to review the literature right now. So comorbidities across the literature are pretty significant. So an MRI study showed that 80% of 205 ME/CFS patients have disc bulging or hernias in their cervical spine, 83% have signs of intracranial hypertension, 64% have obstructions in C1 to T2, over half of spinal cord compressions, C5 to C6, and 28% at C6 to C7. This study unfortunately did not have controls. Over a quarter of ME/CFS patients have severe spine problems in an EHR study, electronic health record study of ME/CFS clinics. 21% of EDS patients have craniocervical instability, and 40% of EDS patients have tethered cord syndrome in an EHR study of EDS clinics. Studies have found similar spinal conditions in a majority of fibromyalgia patients. So 71% of 49 fibromyalgia patients had cervical cord compression in an MRI study, and in another MRI study, 91% of 42 patients had short phylum, which can be indicative of cord stretch injury. While the prevalence of spinal conditions in chronic Lyme isn't known, joint and connective tissue issues such as Lyme arthritis and tendinopathies are associated with chronic Lyme. So these spinal conditions, there are important questions about the roles of these spinal conditions in the pathophysiology and symptomatology of these illnesses. So these spinal conditions themselves have been shown to result in neuropathy, in brainstem vascular nerve compression, in cord stretch injury, so pulling on the brainstem because of the tethered cord being attached to connective tissue, as well as cerebral hypoperfusion. And notably, cerebral hypoperfusion and neuropathy are really commonly found across these illnesses. Symptoms of these spinal conditions overlap with infection-associated chronic illnesses, including neurological, orthostatic, and cognitive symptoms, fatigue, and pain. I'm not really going to talk about this, but I just want to mention that there are important questions about the possible role of brainstem compression and torsion on the brainstem and spinal cord from these illnesses, possibly driving some of the symptoms we see in them. More research is needed. There are also case studies showing improvements in ME/CFS patients and fibromyalgia patients related to their symptoms following spinal surgeries, such as spinal stenosis surgery in ME/CFS patients or cervical myelopathy surgery in fibromyalgia patients. However, more research is needed on surgical outcomes because these can also vary significantly. And a really key question here is, can we understand the mechanisms driving this connective tissue so that surgeries can be prevented and less invasive treatments can be developed? So I'm going to talk about key areas of research focus on possible mechanisms for connective tissue damage in infection-associated chronic illnesses. There is significant immune dysfunction across these illnesses, especially as we know in long COVID and ME/CFS, regarding both innate and adaptive immunity. I hope that more research will seek to understand how trends in immune dysfunction may contribute to connective tissue breakdown. One important consideration here is that mast cell mediators like histamine and tryptase can directly damage collagen. And mast cell activation disorders, as we've discussed, are comorbid within these illnesses. Also, damage-associated molecular patterns are molecules from dead or dying cells and implicated in the innate immune response and ECM degradation. They can perpetuate a pathological pro-inflammatory feedback loops that can damage collagen. Also, MMPs, specifically MMP1, 2, and 9, are enzymes that can degrade and remodel the ECM and tissue. They play important roles in immune responses to infection. So on the right of the slide, you'll see a table where MMPs are implicated in the pathology of acute infectious illnesses, which include pathogens associated with infection-associated chronic illnesses like Borrelia burgdorferi, which causes Lyme disease, or HSV, or herpes simplex viruses, which have been associated with ME/CFS. So one interesting study is that Klinga et al. Found inflammatory cell invasion, including mast cells and leukocytes, in the phylum of HEDS tethered cord surgical patients. There were also important differences in the tissue between patients who had HEDS and those who did not. So in HEDS phylum, it was half as elastic as non-HEDS tethered cord surgical patients' phylum. And this potentially increases their risk for cord stretch injury, so pulling on the brainstem, because of changes in the elasticity of the phylum, and cord stretch injury can cause many of the symptoms that we just spoke about, including neurological symptoms. So I think it will be incredibly important to research this further, and I hope that we see more research like it. Persistent infections have been found in multiple studies, especially in ME/CFS and long COVID. And an important possible mechanism to study is the role of infection in contributing to connective tissue damage in these illnesses. So, for example, HHV6 viral microRNA was found in the brain and spinal cords of ME/CFS patients, including cervical, lumbar, and sacral nerve roots. Evidence of SARS-CoV-2 persistent infection in long COVID patients is found across multiple studies. SARS-CoV-2 infection can reactivate latent pathogens such as EBV, HSV1, HHV6, HHV7. And really interesting, there is a case study of treating Bartonella infection with antibiotics in a 31-year-old woman, and her hypermobility resolved and normalized. She had a Baton score of 7, and it went to 0 following antibiotic treatment for Bartonella. So I am really excited to show you the pictures of the mice below. This is a world first. For us, this is the first time that we are sharing our mouse research on hypermobility following infection. So on the left, you will see a mouse that is uninfected. Its tail is straight. The tail is not malleable. The curve that you see is the maximum that this tail will curve. That curve will not stay in place. It's impossible to tie a knot in this tail. This is a healthy mouse tail. And then on the right of the slide, you will see a mouse following long-term infection. We observed new onset hypermobility in the tails of these mice. The tails become highly flexible and malleable due to connective tissue damage resulting from infection. We are able to tie knots, and the knots will hold. So we are excited to continue studying mechanisms of this and hope to share more about our mouse research on hypermobility following infection as it develops. I also want to talk about some other exciting recent research demonstrating possible blood-based biomarker for HEDS and HSD. So this is a multi-center cohort study that included 466 participants, including 94 people diagnosed with HEDS and 80 people diagnosed with HSD, as well as patients with classical EDS, vascular EDS, and joint conditions such as rheumatoid arthritis, psoriatic arthritis, and osteoarthritis, as well as 150 controls. So plasma samples were analyzed through Western blot and ELISA to identify ECM protein fragments. The study found that people with HEDS and HSD share the same fibronectin and collagen fragment signatures, and that the fibronectin fragments were unique to only individuals with HEDS and HSD. This suggests that they possibly might not be distinct disorders, as they are currently classified differently diagnostically, and they might actually represent a continuum of severity within hypermobility, across hypermobility and illness. The study also identified specific fragments associated with osteoarthritis, rheumatoid arthritis, and psoriatic arthritis. It will be interesting to see if further research could lead to diagnostic labs for these conditions that are blood-based labs, especially for HEDS and HSD. Can we diagnose these conditions earlier? Because current diagnostic delays, according to the EDS Society, are 12 years for HEDS patients. At this point in the presentation, it should not surprise you to hear that this study also found that this group of comorbidities that we've just been discussing are very common in HEDS and HSD patients. The presence of these comorbidities do not correlate with identified biomarkers, and more research is needed on that. So specifically, among HEDS patients, they found that 94.7% experienced chronic fatigue, and this was slightly less among HSD patients. And chronic fatigue, it's important to note, is not the same as ME/CFS. ME/CFS is a neuroimmune illness. Chronic fatigue is a symptom, and it's a key symptom of the illness, but these are distinct things. A majority of both HEDS and HSD patients also experienced gastrointestinal disorders, neurological issues, allergic issues, MCAS, and while these comorbidities were more frequent in HEDS, they were also very prevalent among HSD, which also supports the idea that this may be a continuum of hypermobility as well as illness severity. So I'm going to talk a bit about other less studied pathologies that are shared across illnesses, and I have one slide on environmental sensitivities. So environmental sensitivities and allergies are common across these illnesses, including food sensitivities, and some patients become especially sensitive to their environment. This is something we think a lot about in our clinical study and are hoping to better understand whether these symptoms may be immune mediated. Just focusing on ME/CFS here, although these environmental sensitivities and sensitivities to foods and allergies are present really across illnesses. But within ME/CFS, between 16 and 44% of ME/CFS patients report that environmental toxin exposures cause their illness, most frequently mold and chemical exposures. And you may remember that multiple successive triggers is a common onset pattern. Many buildings have water damage and mold. Whether or not mold exposure contributes to some of the immune dysregulation we see in these illnesses is something that we hope to understand better, or whether, these sensitivities develop as a result of the underlying immune dysfunction and you become more sensitive to them. Environmental sensitivities are also a part of the diagnostic criteria of ME/CFS. So it is part of the international consensus criteria and the Canadian consensus criteria, which are two of the diagnostic criteria for diagnosing ME/CFS. And in our study with Mayo Clinic, we found that 32% of long COVID patients experienced new onset allergy sensitivity and intolerances following COVID. The impacts of these sensitivities can actually be quite severe, including leading some patients to even be homeless because they can't tolerate their homes anymore. These environmental sensitivities might be symptoms of mast cell activation disorders. This is the hypothesis. However, much more research is needed to understand their possible mechanisms and the broad potential immune mechanisms that may be contributing. So the last group of less studied pathologies that I'm going to discuss in our talk is reproductive health conditions and infection-associated chronic illnesses. So I worked with my colleagues at the Patient-Led Research Collaborative to write the first review of reproductive health impacts of long COVID. We contextualize these findings by drawing on research evidence of female reproductive health in illnesses that are often comorbid or maybe associated with long COVID, such as ME/CFS, POTS, and connective tissue disorders like Ehlers-Danlos Syndrome. And I'm proud to say that this paper has had a positive impact. So it's actually the most viewed paper of all time by the journal, and its altmetric score of its comprehensive impact and engagement and how much it's been discussed online in the media puts it in the top 0.2% of papers of all time on any topic. And I point this out not to brag, but because work highlighting less studied pathologies in these illnesses, it's important and it can be impactful, and there's a real need to raise awareness of them. So I think there's a hunger for information on these topics that is sometimes perhaps underestimated. So I hope that we continue to see more research on these less studied pathologies. So to review, premenopausal women have a higher risk for long COVID and possibly for ME/CFS, suggesting that sex hormones and sex differences in immune responses to infection may play a role. To summarize our findings, these illnesses individually have increased rates of infertility, endometriosis, ovarian cysts, uterine fibroids and bleeding, lacking menses, irregular and inconsistent menstruation, intermenstrual bleeding, menstrual cramps, vulvodynia, painful intercourse, early menopause, pelvic congestion syndrome, gynecological surgeries, adverse pregnancy complications such as preeclampsia, maternal mortality, and premature birth. Half to 2/3 of female ME/CFS patients report increased illness symptoms before menstruation. indicating that it may be important for us as a field to consider the menstrual cycle when conducting patient symptom surveys. Women with ME/CFS compared to controls disproportionately report irregular menstrual cycles, amenorrhea, dysmenorrhea, excessive menstrual bleeding, and bleeding between periods. Reproductive health conditions are common yet understudied in ME/CFS. Patients report increased rates of polycystic ovarian syndrome, ovarian cysts, pelvic pain, gynecological surgery, and endometriosis compared to controls. A longitudinal case control study revealed early onset menopause is a risk factor for ME/CFS, and menopause exacerbated symptoms in 38% of perimenopausal and postmenopausal women with ME/CFS. A study found that women who had been pregnant in the previous year were 31 times more likely to develop ME/CFS. Pregnancy is reported as a trigger in both ME/CFS and POTS, accounting for about 3 to 10% of cases. And results are mixed on this, but pregnancy exacerbated symptoms in large subsets of ME/CFS and POTS patients, though subsets of patients also report improvements in symptoms or no difference. It will be important to understand why. Why do some patients report remission or improvement from pregnancy and others experience a progression in their illness? If we understand the mechanisms of this, especially immune mechanisms, could these findings inform directions for research and treatment pathways? Few studies have investigated the impact of long COVID on female reproductive health. That said, we found that emerging evidence suggests that, similar to ME/CFS, long COVID can disrupt the menstrual cycle, gonadal function, ovarian sufficiency, and menopause and fertility. So in terms of menstruation, the menstrual cycle irregularities are common in long COVID patients, including changes to the length of the cycle, to its duration and intensity of the menses. Similar to ME/CFS, studies show that between a third and 62% of premenopausal long COVID patients commonly experience an exacerbation of their long COVID symptoms in the days before menses, as well as a worsening of premenstrual symptoms. In a patient survey of nearly 1,800 menstruating long COVID patients, 34% reported menstrual issues, and within that, 26% reported irregular cycle, and 20% reported heavy periods. So case reports suggest that COVID-19 infection may be associated with a long-term decline in ovarian health, including premature ovarian insufficiency, which is loss of normal function of ovaries before the age of 40. Similar to ME/CFS, premature menopause has been found to possibly be more prevalent among long COVID patients in their 40s than in the general populations. Few studies have investigated long COVID in pregnant people. So recently, a paper was published based on research that's a part of RECOVER study that found that 1 in 10 people who are pregnant and contracted COVID went on to develop long COVID. It tracked 1,503 people across the US in 46 states plus DC longitudinally for at least 6 months who were pregnant and got COVID. And this is really interesting because a non-pregnant arm of the RECOVER trial found that about 23% of adults had symptoms for 6 months following infection. So the pregnant cohort actually had lower rates of long COVID in this study. I also checked the latest CDC Pulse data on long COVID. It's from mid-August to mid-September 2024. And out of all US adult women who've had COVID, 21.8% have developed long COVID, which is similar to the RECOVER statistic. And that number is 15.3% for US males who have had COVID and 18.4% overall. So, and they defined long COVID as new symptoms lasting 3 months or longer following COVID-19. However, it is worth mentioning that a small control matched prospective cohort study in Brazil followed pregnant women after testing positive for COVID-19. It was a study of 84 women, and 76% developed long COVID. So this is possibly reminiscent of research that has found pregnancy as a risk factor for ME/CFS as well. So it will be important for research to further study whether pregnancy may be a risk factor for long COVID and how long COVID affects pregnancy. I also want to mention, within the context of long COVID and reproductive health, that our Mayo Clinic paper that we just published found that 61% of long COVID patients reported that they had a genitourinary condition newly develop or become worse following COVID. ME/CFS, POTS, and long COVID and EDS share many reproductive health conditions, symptoms, and menstrual irregularities, as you can see in our figure. Similar to ME/CFS, in POTS, studies have found increased rates of dysfunctional uterine bleeding, secondary amenorrhea, uterine fibroids, endometriosis, ovarian cysts, and pelvic congestion syndrome. In POTS, menstrual cycle hormones have been found to affect hemodynamics, and menstruation is associated with an increase in symptoms of dizziness. There was a study published recently that found elevated levels of different kinds of sexual dysfunction in female and male POTS patients, including arousal, erectile dysfunction, and more. In EDS, if you look at the pregnancy column, it is associated with increased risk for a host of pregnancy complications. So limitations of many of these studies include lack of healthy control or comparison groups, not screening participants for comorbid illnesses, a lack of consideration in the study design of factors that may impact menstrual cycles, such as vaccination. So again, I stress the need for more research on reproductive health in infection-associated chronic illness, and really more research on less studied shared pathologies across illness. Here I'll discuss endometriosis in particular. Research suggests that between 20 and 36% of female patients with ME/CFS report endometriosis, and 20% of POTS patients do. So that is between 2 and 3.5 times general population prevalence for endometriosis. Critically, the average time to diagnose endometriosis from symptom onset is 7 to 10 years. In regards to long COVID, a study of non-hospitalized COVID patients found that patients with endometriosis may have an increased risk for developing long COVID, but more research is needed to understand contributing factors. People with polycystic ovarian syndrome were found to have a 28% increased risk for COVID-19 infection after adjusting for other risk factors. And interestingly, research suggests that ME/CFS and endometriosis may share some overlapping immune and endocrine dysfunctions, which are listed on the slide. So as this is a high-level overview, I am not going to go too deeply into a discussion on possible mechanisms of endometriosis, though that's a very important discussion to have. But I do want to mention an interesting area of emerging research is whether infection and possibly immune mechanisms to it may contribute to the development of endometriosis. So last year, a study found that Fusobacterium I'm going to restart this slide because I tripped over my words. So, okay, restarting this slide. As this is a high-level overview, I am not going to go too deeply into a discussion on possible mechanisms of endometriosis, though that is a very important discussion to have. But I do want to mention a very interesting area of emerging research is whether infection and possibly immune responses to it might contribute to the development of endometriosis. So last year, a study found Fusobacterium in endometrial tissue of 64% of 79 women with endometriosis and in just 7% of healthy controls. So mice that received a transplant of uteri tissue infected with Fusobacterium grew endometrial lesions, and mice with uninfected tissue, a transplant did not. Antibiotic treatment reduced Fusobacterium and the weight of the endometrial lesions in mice. So on the right of your side, you'll see images from our mouse research. So in the TAL research group at MIT, we are studying mouse models of infection-associated reproductive tract pathologies. I am excited to share with you some of our striking preliminary findings. So the mouse on the left is an uninfected mouse. It has normal uterus, normal ovaries, normal reproductive tract, and the mouse on the right was infected with a pathogen, and you will see that it developed severe reproductive tract pathologies, including enlarged and inflamed and infected uterus, ovary, and reproductive tract. There are many outstanding questions about the roles, mechanisms, and impact of reproductive health conditions in infection-associated chronic illnesses, as well as in EDS and HSD. We highlighted some of these in our review. They include examining the role of sex hormones and mast cell activation within menstrual cycle-related fluctuations of illness symptoms. Additionally, how might hormone fluctuations in the menstrual cycle impact connective tissue laxity, and how might this contribute to illness symptoms? Important areas for future future research include examining menstrual and reproductive tract microbiomes in infection-associated chronic illnesses and exploring possible pathogen persistence in the reproductive tract, which we are doing in our clinical study at MIT. It will also be important to develop less invasive diagnostic approaches to endometriosis and reproductive pathologies to better understand them and decrease diagnostic delays. Okay, so far I have discussed the overlaps across illnesses, both in terms of symptomatology and onset patterns and risk factors. I've also delved into the prevalence of hypermobility in infection-associated chronic illnesses and possible mechanisms, and even research on a possible biomarker. I also discussed spinal conditions, environmental sensitivities, and reproductive conditions within these illnesses, all of which are less studied topics. So what is next for research on hypermobility and connective tissue disorders within infection-associated chronic illnesses? In our lab, this is a topic we integrate into our clinical studies and into much of our research, including our mouse research, and I hope that this will be a key topic in the field. So I've outlined some research priorities and kind of key questions for the field. So one, why is hypermobility and connective tissue disorders overrepresented in these illnesses? How might infection and immune responses contribute? Can we develop methods for predicting, prevented, and non-invasively treating connective tissue disorders within these illnesses? Importantly, what are biological mechanisms and biomarkers, especially of acquired or exacerbated or new onset connective tissue disorders after developing an infection-associated chronic illness? Some kind of key areas for research include the roles of infection, bacterial, viral, fungi, and environmental exposures, immune and inflammatory mechanisms, and sex differences in them. Possible metabolic and mitochondrial mechanisms, and the role of oxidative stress. Mitochondrial dysfunction is a really important mechanism in long COVID and ME/CFS research, and there are a lot of questions about how it might contribute to both connective tissue breakdown as well as impaired wound healing. It's important to study genetics and the role of germline versus somatic mutations, possible roles for reduced perfusion to tissue and hypoxia, reduced perfusion and hypoxia and oxygen extraction issues, and cerebral hyperperfusion, and just perfusion in general is a really important area for research within long COVID, within ME/CFS, and likely really across these illnesses. And there's also some emerging research on the role of nutritional deficiencies in some connective tissue disorders that could be explored more as well. A lot of research on EDS has focused on genetic causes, and this is a very important research topic. As we know, genetic markers haven't been identified yet for HEDS or HSD, and HEDS is the largest subtype of EDS, and HSD and HEDS and joint hypermobility are very common across these illnesses. So I think it's important to expand our research to also look at other potential triggers and contributing factors beyond genetics, including genetics, but beyond genetics, and how they might be contributing, such as the factors in this list. I think if we don't expand research in this way, we are potentially leaving out a large proportion of people who are affected by symptomatic hypermobility within these illnesses. Other topics for research and to really kind of help fill some of the research gaps and key questions that exist include epidemiology studies, so our EDS and HSD and hypermobility risk factors for all of these illnesses. We know some about long COVID. It's important to study this across. What is the prevalence of pre-existing and hereditary connective tissue disorders versus a newly acquired, new onset in these illnesses? In which orders do this group of illnesses typically develop? That can be hard to study in electronic health record data because of issues with diagnostic delay and underdiagnosis, but it's an important question nonetheless. And something that I've talked about a lot in this presentation is, are there phenotypes of patients with hypermobility across these illnesses? For clinical research, key questions include how do connective tissue disorders impact the pathophysiology and symptomatology, as well as illness trajectories and severity of these illnesses? How might these illnesses contribute to the development and progression of connective tissue disorders? And can we include screening for hypermobility and spinal conditions and connective tissue disorders really standard as a part of infection-associated chronic illness research, and as part of screening for common comorbidities? Though I will say, hopefully we can include screening for the most common comorbidities standard within research as well as part of our research approach. In terms of therapeutics, can we identify therapeutic targets and non-invasive treatments and identify them as research priorities? And for evaluation and diagnosis, can we develop diagnostic and predictive tools for comprehensive whole body evaluation for connective tissue disorders that go beyond, just hypermobility and Baton score? Baton score assesses, far fewer joints than we have in the body, 9 versus hundreds of joints, and there are many areas that may be impacted by hypermobility that we don't necessarily assess for if we're only screening for hypermobility using Baton, but that is a much larger conversation and worthy of its own presentation. So I hope we see more validated instruments, including surveys, more testing and measurements, imaging, serology, physical assessments, biopsies, more comprehensive hypermobility screening, as I mentioned, hopefully including but also going beyond the joints assessed in Baton. And I hope that we can establish a working group of scientists and clinicians and patients, with people with lived experience in the community, to come together to define research priorities, screening tools, and share findings and collaborate on research. So I want to mention that in January of this year, I was honored to lead and organize a 4-hour research webinar on less studied pathologies of ME/CFS for the NIH. And this was the first time that the NIH has ever discussed hypermobility and connective tissue disorders and spinal disorders within ME/CFS. I also chaired the Less Studied Pathologies subgroup at the NIH, which was a part of the ME/CFS Research Roadmap Working Group, where we were tasked with designing a comprehensive research plan to advance ME/CFS towards clinical trials and therapeutics research. And so this was really the first time that this group of less studied pathologies, which included spinal disorders and connective tissue disorders and reproductive health and mast cell activation disorders and gastrointestinal conditions and neuroendocrine dysfunction, it was really highlighted and included as part of main research priorities within ME/CFS. And I think this is the first time that these topics were included within research priorities for one of these infection-associated chronic illness, at the federal level. And so I wrote the sections of the report on less studied pathologies for the national research plan, and I've adapted some of those priorities here within these last few slides. So anyone who wants to learn more, this webinar is online, and we go into discussions and research presentations on many of the topics I've discussed here today, including connective tissue disorders and spinal disorders. I'm going to overview research on priorities for spinal conditions in infection-associated chronic illness. This list was also adapted from the research roadmap, and I authored those sections of the report. So it will be important to study how to prevent the development of spinal disorders and to identify therapeutic targets and non-invasive treatments like immunomodulating therapies. Hopefully these surgeries will be an absolute last resort, and we will be able to predict and identify early patients who are going down that path and address with non-invasive treatments. I hope that we see histology and high resolution imaging research and really an in-depth analysis of neurosurgical tissue to be able to identify tissue-based biomarkers and mechanisms of this connective tissue damage underlying spinal disorders. I mentioned Dr. Klinga's important research characterizing the phylum of HEDS patients who've had tethered cord, and I hope we see more of that. So research on craniocervical ligaments, muscle, nerve and nerve roots, and more. I hope that we see multiomic and immune and pathogen profiling of this neurosurgical tissue as well as fluids, and that, it would be great if we could set up a tissue bank to really enable this research and enable collaborations between labs with this kind of expertise. It will be important to screen for spinal disorders and infection-associated chronic illness research, and to study their prevalence and to identify potential biomarkers. I hope that we can validate accessible, low and no risk assessments in research and clinical practice. I know that some physicians are looking at approaches to looking at, heel-toe walking as a possible indicator for cathetered cord, or looking up, down, inflection and extension, left and right for craniocervical instability or atlantoaxial instability, or, pressing in front of the ears or the mandibles for eagles. And so I hope that we can validate this kind of non-invasive testing so that we can incorporate screening for these conditions in studies, even if these studies don't have MRI imaging as a component. I also hope that we see MRI studies to look for these spinal conditions in these illnesses, and it will be really important to better understand the roles of spinal conditions in the pathophysiology, disease trajectories, severity, and symptomatology. As I mentioned, there are some hot topics that require more research, such as the role of brainstem compression in driving some of the symptoms that we see in these illnesses and whether that might be contributing. I hope that we see deep phenotyping studies on research for looking at risk factors and triggers for developing these conditions. I also hope we see research analyzing and ideally predicting neurosurgical outcomes so that we can better understand who is most likely to benefit from this surgery, and if we can really predict the range of outcomes from these surgeries to hopefully improve them. So I hope that we see more research specifically on HEDS and HSD within these illnesses, but I also hope that we, as a field, take a cross-illness approach to this illness. It's important to study these illnesses individually, but it's also important to study them within the context of one another and how and why they co-occur. So there's really a need for cross-illness research with multiple illness comparator cohorts. We need funding for clinical trials and clinical studies with multiple illness cohorts. We need standards and models and protocols for effective cross-illness research. We need research to comprehensively screen participants, not just for HDS and HSD and spinal conditions like I just mentioned, but really all of the common comorbidities, and really develop the protocols to best do that and validated instruments. We need mechanistic research on many of the pathologies in these illnesses, both commonly studied and understudied. I hope we see more research on severe and highly complex patients. These are the patients who develop multiple comorbidities simultaneously and tend to have a much worse quality of life. Just within ME/CFS, 25% of people with ME/CFS are housebound or bedbound. Many can't work. So if we can predict and prevent and treat people on paths towards this kind of severity and multimorbidity, can we preserve functionality? That would be really high impact research that could potentially help a lot of people. Also, I hope that we see collaborative working groups in the field asking these questions and collaborating on cross-illness research, and to develop research priorities, not just for our most commonly studied pathologies, but also our less studied pathologies. There are very important research gaps in our research right now of understanding how these illnesses, why people's bodies are essentially falling apart in many different ways. And I hope we see working groups on therapeutic research priorities, or research priorities on therapeutics and for clinical trials. And I hope the field advances towards clinical trials, studying, promising medications and off-label treatments, and that this is informed by patients and people with lived experience. And then in terms of healthcare. Similarly, I hope that we as a field can move towards a healthcare model that really takes into account screening for these comorbidities and common and less common studied pathologies. We can raise awareness of these pathologies and hopefully reduce diagnostic delays. Many patients commonly see multiple doctors over many years before being diagnosed. And it's also worth mentioning that there is a need for more physicians specializing in these illnesses. So just a quick search of the number of illnesses. So within the ME/CFS Clinician Coalition, which is a coalition of specialists in ME/CFS, there are 21 members listed for about 2.5 million patients with ME/CFS in the US, though that number is likely actually underestimated. The Mast Cell Disease Activation Society directly lists only 33 specialist physicians for an estimated potentially up to 56 million Americans with MCAS. And the American Academy of Neurologists membership includes about 129 autonomic neurologists for an estimated 3.1 million Americans with POTS. And so there's very much a need for cross-illness treatment and kind of clinical approaches, but also we need more specialist physicians, which is why events like today are so important. And I hope that we see more dialogue and collaboration between researchers and clinicians, like we set up our collaboration between MIT and the Mayo Clinic. I hope that there is so many more collaborations like this, because I think that the clinical perspective as well as patients' lived experience perspective are integral for informing research processes and priorities. So this is, if I didn't include a reference on a slide, here is a reference list from the presentation. And then I also want to thank the TAL Research Group at MIT. So thank you so much to you for attending my talk. And we are an immunoengineering lab in the MIT Department of Biological Engineering. We're led by Mickey Tall. We're based in the MIT Center for Gynepathology Research. We study infection-associated chronic illnesses, including acute and chronic Lyme, long COVID, ME/CFS, and their associated pathologies and co-occurring conditions like hypermobility conditions and EDS and connective tissue disorders. And we focus on translational science, which is why it's especially meaningful to talk here today with an audience of physicians and lived experience, people with lived experience and researchers coming together to discuss this really important topic of hypermobility within infection-associated chronic illnesses. Thank you so much.